Dr. Murphy has focused his scientific breakthroughs in clinical practice to aid patients in spinal cord injuries and spinal pathology as well as nerve injuries. His clinical practice has included over 400 complex spine, cranial, and peripheral nerve cases a year. He's the neurosurgical medical director at Deer Valley Hospital, which we all know is a level 1 trauma center, and a primary investigator on a number of impressive trials, including a Department of Defense cervical spinal cord injury trial, congressionally directed medical research program in peripheral nerve imaging as a co-investigator, sub-investigator on 2 investigational medical device trials for very interesting fully implantable wireless brain-computer interface. Again, so really on the forefront of brain injury and spinal cord injury. Has collaborated with NIH and DoD grants currently totaling over $7 million over the next 4 years in both direct and indirect costs. He's an ambassador for myelopathy.org, a patient-run organization to raise the awareness of degenerative cervical myelopathy, one of the most common causes of spinal cord injury in people, particularly in people over 50. People over 50 tend to fall. They tend to have pre-existing cervical spinal stenosis and can end up profoundly impacted as a result of that. So I have the pleasure of introducing Dr. Rory Murphy.
Thank you very much, Fred, and thank you very much for everyone for being here. It's a huge turnout today. Seems to get bigger and bigger every year. So what I'd like to do now is basically try and distill and just give simple information on predominantly cervical myelopathy, which is a very degenerative cervical myelopathy. So looking at wear and tear and arthritis pressing on the spinal cord and how it presents, what research we're doing, how we're trying to empower people with the condition so that they can manage their own disease. And it's unfortunately a misunderstood, extremely common problem that we all need to know more about, and I'm continuously learning about. My first research work on it was back about 2007 when I looked at the natural history of cervical myelopathy in Ireland. And unfortunately in Ireland, people were on waiting lists for long times with diagnosed cervical myelopathy, and we got to see how the natural history of it gradually worsened with time. And since then, I've always been fascinated by cervical myelopathy and trying to do how to research it more, figure out how better to treat it, do better surgeries. I'm going to focus more on decision-making and education and the condition rather than the surgeries for this talk. We've got lots of good ways to help surgically, but that's almost the easy part. It's figuring out who, if, and when to treat and how to help people recover is probably the most important part. So this is what we're mainly talking about, pressure on the spinal cord. And here's a graphic showing how we're trying to raise awareness and shed light on problems with the spinal cord. Degenerative cervical myelopathy is a common condition. It's the most common form of spinal cord injury around the world. And it affects 1 in 10 people over 50. And the problem is, the presentation can be very subtle because generally, it can happen in 30-year-olds too, but more likely it's happening in 60 and 70 and 80-year-olds. And it can be misdiagnosed or confused with other conditions. So when people come into clinic or into the ER, some of the more common symptoms are neck pain. About half of the people have neck pain, so not all. So 50% of people have neck pain, not everyone. Numbness and tingling in the hands, difficulty with fine motor tasks, unsteady walking, and potentially falls. I have to stay over here.
Do you want to wear this?
Yeah, sure. Might show the pictures too. Yeah.
Pocket. There. Oh, button.
I'll put it on here.
Yeah.
Thank you. So, I want to thank you. I can walk around it. So, numbness and tingling in the hands, dropping items, and unsteady walking. And those are kind of some early signs. Other symptoms can be pain up into the jaw and bowel and bladder dysfunction as well. And the problem is no one has the same symptoms. Most people have maybe 2/3 of symptoms similar to other people, but everyone has one or two of their own symptoms that can be tricky to figure out. Numbness and tingling, ants crawling in their arms, and that's what makes it very tricky to figure out. It comes on often insidiously and slowly. So a lot of people just put it down to old age, getting clumsy, osteoarthritis in their hands. If you screen people with hip fractures, about 20% will have coexisting cervical myelopathy. So it's the age group, and also the cervical myelopathy may have been the precipitating or part of the reason they had the fall causing the hip fracture. So it's incredibly common and something we always should be looking out for, especially when we're seeing people in the ER and in our clinic. And what are the common causes? The most common cause is degenerative cervical myelopathy. So you can see here on this MRI, severe narrowing at 2 levels with core compression. And that basically then disrupts the signals from getting from the brain down, okay? And it's very hard to explain. So working with our video team, we've worked on special videos to try and explain the condition. So the normal spinal cord has room around it, and then as you get older, you can get disc degeneration. The disc starts to bulge back and start pressing on the spinal cord. This is a normal diagram here, showing the cord with plenty of room around it. You have your CSF around it. Common misconception is that it's the narrowing blocking the CSF is the issue. No, it's actually more of a movement-related issue and pressure on the spinal cord. Very commonly, it's usually the pressures at C5 and C6 and C6 and C7, lower down in the spine. And this is the posterior longitudinal ligament can get calcified. That's a really common problem in Southeast Asia. And OPLL, or ossified posterior longitudinal ligament, is very common in Japan, Taiwan, and Korea. And that's why a lot of our research comes from there. So we use the modified Japanese Orthopedic Association scale to quantify a person's symptoms. The key here is it's a dynamic disease. You're always moving your neck. So you're always, when you have this narrowing, you're always rubbing against the spinal cord. And then gradually with time, you can develop scarring of your spinal cord. And this is when it starts to get to a more severe stage. Now, what does this mean? Well, the scarring and disruption to the axons and the myelin sheaths then disrupts the normal signals that go down from your brain to your arms and legs and help you control your hands. But also, it disrupts the signals coming back up again. So you lose your proprioception. One of my patients described it, for about 2 years, she felt like she was on a boat. She was always unsteady. She felt she was always rocking around a boat. And immediately after surgery, she felt calm and steady, and she felt a lot more at ease. Now, it doesn't always improve straight away after surgery when you take the pressure off the cord, but that was one nice example. And so that's how it disrupts the signals. So how do we look after somebody? Sometimes people will have severe narrowing around their neck. I had a GI physician actually last week, gastroenterologist. He had severe stenosis around his cervical cord. He had an MRI for another reason. They saw it. He got a phone call from Simon Med saying you've got severe stenosis. You need to see your doctor straight away. You could be paralyzed. Very unlikely. Your chance of being paralyzed from severe stenosis is very low, thankfully, in most cases. Okay, so that's one common misconception. This is something that generally gets worse slowly over time. Some people can rapidly deteriorate, but most people slowly get worse. We don't know really why, and we're trying to figure that out. I'll talk about it shortly. So some people will come in, they'll have severe spinal cord, but they'll have no symptoms. And what do you do in that situation? Well, we surveyed, and we'll show you the results shortly, we surveyed 800 surgeons around the world, orthopedic and neurosurgeons, and there was no good consensus, unfortunately. So we don't have an exact way to look after somebody like that, but the general consensus was you can do close observation if someone has no major symptoms. And then people with mild symptoms, so they might have some mild numbness and tingling in their fingers, some mild unsteadiness, but they're able to walk up and down the stairs fine and no falls. What do you do with a person with mild symptoms? It seems to be you can potentially observe them with structured rehabilitation and a close follow-up at about 6 months, or you can do surgery. And that's per the AO spine guidelines. And we're working on better guidelines for the future. And we're going to talk about some of the imaging techniques we're using too. It's a bit easier when someone has severe symptoms, basically you need surgery. Because what happens is you gradually get worse. And we'll talk about the timing of surgery shortly. So severe symptoms is easy. Asymptomatic is easy. It gets very tricky in the middle range when you've got mild symptoms and you're trying to decide what will help the person best. So, why does somebody have severe stenosis and have no major symptoms, and other people have about the same amount of narrowing? They've got terrible symptoms. They're almost quadriplegic. They've got severe limitation in their arms and legs. We believe it's down to the motion and the movement. So not only stenosis, but how your spine is moving and how it's compressing your cord and how your cord reacts to that pressure gradually over time, and how your blood supply and edema and what it's causing. So mechanical stress is very important on the progression of disease. And so the mechanical stress can cause an injury called edema, a partial injury, and then you may recover partially, and then you have a stepwise deterioration. And oftentimes you may be okay, and then you can deteriorate pretty quickly over 6 to 12 months because this cord loses its innate ability to heal itself. So that's very important that we need to figure out better what exactly is happening in the spinal cord and causing this gradual worsening. And we're doing research to figure that out. So when someone comes to us with degenerative cervical myopathy, how do we figure out how to help them? Well, the first thing is generally we have an MRI. We'll get flexion extension x-rays to see how the bones are moving, see if they're slipping or if there's spondylolisthesis. That can worsen the mechanical stress on the spinal cord. And then we look at their symptoms, so the modified Japanese Orthopedic Association scale. So we always do a modified Japanese Orthopedic Association scale on every person to try and quantify their symptoms. So if we are going to do close observation, we have objective information on their symptoms. So when they come back in 6 to 12 months, we can go do it again and say, look, actually, yeah, you've had a 2-point drop or worsening of your symptoms. You are getting worse. We probably should intervene and do surgery now, if that makes sense. Where do our guidelines come from? So the best evidence and best guidelines at the moment are from the AO Spine Group, a collaborative group of orthopedic surgeons and neurosurgeons from around the world. And if you're in Johannesburg, if you're in Tokyo, if you're in Phoenix, we kind of all use the same guidelines, okay? So if you go into a spine surgeon in any of those places, you'll probably get this advice. So if you have mild myelopathy or an MGOA of 15 to 17, lower scores are worse. 18 is normal. You can't really get down to 0, hopefully. But you're 15 to 17, we can maybe offer surgery depending on the symptoms or close observation over 6 to 12 months. If you see a worsening of symptoms, you should probably do surgery. And if you have moderate to severe myelopathy or an MGO of less than 15, you should do probably surgery as well. So that's our general guideline. These guidelines came out in 2017, and they're at the moment our best evidence of what to do. New guidelines are being developed right now by the AO group, and they should be published in the next year or two. Some of them are coming out as we speak, so we should have some updates soon. So this is the paper we're just submitted to Nature Spinal Cord Injury, looking at management of mild cervical myopathy and asymptomatic cervical myelopathy, where we surveyed basically of 6,000 spine surgeons around the world. We got 800 responses back. And we asked them, if you have a patient with asymptomatic stenosis, what do you do? Varied remarkably within the US, around the world. Or if you have someone with mild myelopathy, what do you do? The general consensus is you observe them if they're mild or asymptomatic, but it shows there's no good consensus among surgeons. So this is a big problem. We should have some consensus to help guide us. And that paper will come out probably in the next month or two to help figure this out. So when do you intervene? If someone's got really bad symptoms, it's easy. But when should we intervene? It seems like approximately within 6 to 12 months of the onset of symptoms, or at least a progressive worsening of symptoms. If you leave it longer than that, the worsening of symptoms, the damage becomes permanent. And how do we know this? Well, the AO group did a study with Dr. Failings in Canada and Lindsay Traylote. She's actually from Cork City as well, or she went to university, the same university I went to, where they looked at 236 people across North America, and they looked at when they had their timing to surgery. And they found that if they had, when their symptoms got bad and started progressing, they had it within 6 months, they generally did better long term. So it seems like if you have somebody and they start to get worse and they start to progressively worsen, intervene within 6 months. Now, you might think 6 months is a long time, but the average diagnosis can take 7 months before someone sees their primary care doctor, gets assessed, gets their MRI. They may not get a diagnosis at all. So that's why we're really trying to raise the awareness of the condition. Unfortunately, despite early intervention, usually recovery is not complete. Usually there is some partial spinal cord injury. But if you intervene earlier, there's less. And unfortunately, looking at almost 800 patients with this AO spine group, we found that greater than 70% waited more than 6 months to be diagnosed, which is a big problem. And we're trying to fix that. We're trying to educate more people on the condition so that earlier intervention can be carried out. Here's the data on the North American study and looking at the timing. So this is where our information comes from, the 6 month data, and actually follow-up data from Dr. Failings and the team showed within 4 months. And why is it so important? Well, with cervical myopathy, unfortunately, 36% of people are unable to return to work when they have the diagnosis, even after surgery. 42% require help from others, and only 95% make only a partial recovery after surgery. So unfortunately, only a few, 5% make a full recovery. So that's why we try to intervene sooner. One of the biggest problems is I look after people with acute spinal cord injuries. It's very easy to explain. Someone crashed their car, they fell off their horse, they crashed their motorbike, they had a spinal cord injury. It's very obvious, and they're weak in their arms and legs. And acute spinal cord injury gets a lot of funding every year. Multiple sclerosis, billions of dollars every year. ALS, again, billions of dollars. But degenerative cervical myopathy is more common than all of them, and only gets $47 million a year in research funding. So that's some of the problem. Despite it being a more common condition causing more disability, it's only $47 million in research a year. And thankfully, we're trying to fix that. You can see papers on spinal cord injuries in the red. So I try to do research on both. But spinal cord injury papers are increasing. Degenerative cervical myopathy papers are increasing, but they're still only a very small amount. So we're trying to work more on the research side so that we can answer the questions that we don't know the answers to: when, how, what's the best surgery, but we're still very much in infancy and trying to figure out better what to do. One of the things I'm most excited about is we've put together the first international collaborative effort so that a person who is being diagnosed with degenerative cervical myopathy can be in charge of their disease. So we have, as part of all these efforts, gathering data from surgeons around the world and research from around the world, we're putting together a core information kit. So when you are diagnosed with degenerative cervical myopathy, every spine surgeon or every primary care doctor or every rehab doctor has a core piece of information that everyone should get, detailing the core pieces that will help them be in charge of their disease. So we're working on that. And then we're also, so then when someone comes in, because we are lacking some information, they can then share the decision-making process. So they can be in control of their disease and get a better outcome. And this is amongst pretty much all the major neurosurgery centers across the world, centers from Canada, Europe, everywhere. And we're part of this group doing this paper. And this paper just came out this month. And how are we doing the core information set? Well, basically, we've analyzed all the data, looked at all the research out there at the moment, both published and actually information on websites, newspapers, magazines, patient-focused or patient area-focused information. Then we've asked people with a condition what they need, physical therapists, pain management doctors, rehab doctors, what they need, surgeons, what they need. And we came together as a group, and now we're working on this core information group through consensus and a Delphi process. So we've gone through phase 1, and we're actually gone most of the way through phase 2, and we're on to phase 3. And so now we're down to the bottom. We're piloting the final core information kits. So we're getting them out into clinics so that every patient will have a core piece of information describing their condition in good, simple terms. We're also making sure that it's in Spanish and basically every language that our members are in, so that it's easy to give to people. One big problem we have is, so we can see pressure on the spinal cord on a standard MRI, but we have no information on the structural integrity of the spinal cord. We have no information on how much edema is in the cord, how much demyelination is there, and how much axonal loss is there. If it's all edema, when we take the pressure off the spinal cord, it probably will get better. Can't guarantee it, but it probably will. If it's demyelination, there's a potential for it to remyelinate over 18 months. If it's all axonal loss, it's probably not going to get better. So we're working on a special diffusion imaging, and we've gotten money from the National Institute of Health and Department of Defense, about $7 million actually, to do special MRIs that can actually figure out what's happening in the cord better. And when we started doing the study, started doing the imaging, the big problem we had was, well, thankfully people were getting diagnosed and getting treated, but afterwards, when we were trying to follow their scans over time, the metal artifact from their surgeries was basically stopping us from following them after the surgery. So the team, Dr. Dortch, Richard Dortch, an excellent scientist, and Dr. Lee, excellent research radiologist, have worked on a special protocol that can mitigate or reduce the artifact from the implants. And you can see some of the pictures here. So on the left-hand side, with the blue dot, is a normal MRI after surgery. You can see that you have enough information to make clinical plans. When we try and do the special diffusion MRI, it's completely blocked by the metal artifact. So, and then on the right-hand side, the initial developed sequences, we can actually pull out the spinal cord and look at the structural integrity of the spinal cord. So when someone comes to us, I can say, look, it looks like your spinal cord is 80% edema and swelling, 5% demyelination, and 10% axonal loss. I think you'll probably do pretty well after surgery when the edema starts to go away. Or, unfortunately, it looks like it's 90% axonal loss and 5% edema. It's probably not going to go as well. Or if you have somebody with mild symptoms, we can do the MRI on them over time and say, look, you've noticed some small changes in symptoms, and actually on your spinal cord MRI, I'm seeing more edema and swelling, and you're starting to get some axonal loss. We should intervene now. Or actually, it looks okay. We can probably try and push it a bit further, wait a bit longer. I've been mainly talking about cervical myelopathy because it's probably the more insidious, difficult one to figure out. Radiculopathy is a very common challenge we deal with every day, but usually it's actually diagnosed pretty quickly because often pain is a major component. So people will come in with severe electric pain, shocks down their arm, and usually they get diagnosed pretty quickly. And we've got lots of good ways to help. The same surgeries are used for cervical radiculopathy and cervical myelopathy. Take the pressure off the spinal cord and the nerve. When I started out, when I was a medical student, I found it very hard to understand the difference between degenerative cervical myelopathy and radiculopathy. Basically, myelopathy is pressure on the cord. Radiculopathy is pinching of an individual, or maybe two nerves, but not the cord. So that's just important to know. You can see a picture here showing the pressure on the nerve as it exits the foramen. And generally, the key is conservative treatment, try physical therapy, injections. If they fail after maybe 8 to 10 weeks of conservative therapy, if it's severe pain, it's not getting better, or if someone's getting severely weak in their arm, we would do surgery to take the pressure off the nerve. And we've got lots of nice ways to take the pressure off the nerve with a anterior approach, or from the front, an ACDF, or an arthroplasty, which is becoming more common these days as we get more data on them, or going and doing a foraminotomy, going in the back and doing a posterior foraminotomy. It's a common problem. Elon Musk had an arthroplasty about 5 years ago. Peyton Manning had a fusion for his symptoms. So it's a common problem with the average age being approximately 51 years of age for symptoms to start developing. So lots of good ways to help. So I'd like to say thank you and open up for any questions you have on degenerative cervical myelopathy.
Question.
I heard you mention doing MRI under flexion and extension. Is that a standard order, or is that something that you have to specifically order, like as a surgeon?
So we do cervical x-rays, flexion extension x-rays every day. Cervical MRIs, flexion extension MRIs are a lot rarer. They're hard to get, and a lot of people will find it difficult to do it in the bore. Generally, I'm doing cervical flexion extension MRIs on younger people who may have a hypermobility issue that we're just not really figuring out on the static MRI, where you're lying down with no forces on your spine. So cervical flexion extension MRIs are rare. I would only do I'd only see maybe 1 or 2 a year. Is that your experience, Fred?
Yeah, I would agree with that. You know, it's interesting, some data would suggest that the spinal cord moves up to 2 centimeters when you flex or extend your neck. And so you can imagine the consequences of having compressive pathology when the spinal cord wants to move when you move. And so this constant shearing effect of the osteophyte, the disc, et cetera, can have devastating consequences. It would be nice if we had more access to that, but it's just not typically done, nor is it commonly seen.
For your patients that are stage 1, we're still monitoring, is there anything that you can teach them or have them do to actually prevent or decrease the progression of the disease, or are we simply waiting until it gets worse?
I always recommend physical therapy. So mainly, first thing is try and be as healthy as you can. So reduce your body weight, get to your ideal body weight, stay active, start physical therapy. Often with physical therapy, muscle groups will be improved, core will strengthen, better posture. That can improve the situation up to a point. Strengthen the neck muscles, can reduce some of the forces on the spinal cord. They are working on patient trackers. So as a group from the University of Cambridge working on a project called MoveMed, where essentially your iPhone will be an objective measurer of your function. And so it watches your movement, sees your gait, knows if you're having more stumbling episodes, and also you do a finger tap test on it once every week or 2. And if it starts seeing your finger tap test is getting worse, then it will alert you to having a potential worsening of your condition. The best tests, unfortunately, are not the easiest ones for our people in our clinic. So the 9-hole peg test, where we ask the people to use 9-hole peg test, I guess you can do that at home, but no one really would. Grip strength, is a good one. It's probably useful at home, but not very well. The 60-meter walk test, it's kind of tough to do at home too, you know what I mean? And so we don't really have good objective measures that can be used by a person in their home. And so they are working on cell phone techniques to do that.
With those same patients, if you get another MRI, if they've done physical therapy and they're working towards getting better, have you ever seen imaging that will reflect the improvement, or will the imaging stay pretty similar once it's begun?
It really depends on what the compressive material is. So if it's primarily bone or osteophyte, generally not. But a lot of times you will see a soft disc herniation improve with time. That's very common. Most soft discs actually improve with time. So yes, you can sometimes see improvements. We don't normally use MRI as a observation tool. What's more important is what somebody tells me. So if they come in and they say, I'm getting worse, that's more important than anything else. Because it's very hard to pin down. I would never use imaging to guide my treatment. It's always what the person is experiencing and feeling rather than the imaging. But sometimes if it's soft material, yes, it will improve. If it's bony material, probably not.
Animal models have always informed our understanding of disease processes in man. Do you have any animal models?
There are some rat models of OPLL, of ossified posterior longitudinal ligament, but no, there aren't any. Actually, I'm sorry, there are some. Some dogs do get cervical myelopathy. Actually, most of our surgeries come from horse surgery, so equine surgery. So horses get wobbler syndrome or cervical myelopathy, and the anterior cervical discectomy and fusion or corpectomy, the approach actually came from equine or veterinarian surgeons. So the AO group also includes veterinarian surgeons. I actually had a cowboy from Globe, and he had cervical myelopathy. I explained the condition to him, went through, and he was like, oh, my horse had that condition 3 years ago. He had surgery, he did great. So we did surgery, he did very well. So certain horses, especially quarter horses, do develop degenerative cervical myelopathy quite commonly. But it's not really something we're doing much basic science lab work on.
Thank you.
You know, I'm glad to see that we're developing a more scientific approach towards deciding who should be a candidate for surgery, who shouldn't, and is there a way of assessing you non-operatively. I always struggle with the patient who comes in and has high-risk behavior, has profound cervical spinal stenosis, cord signal change, and they do motocross, or they're competitive skiers, so they like to water ski. Would you ever do it prophylactically because of habits and lifestyle?
Yeah, that's probably the most difficult situation. There is a slight increased risk when you have less room around your cord and you're doing high risk activities. So if they have that, I'll probably say you should probably avoid mountain bike riding, horseback riding, and severe strenuous activities like wrestling, potentially football, and that can be a big problem. So if it's somebody who goes horseback riding for recreation, it's not really much of an issue. But if it's a professional jockey, that can be more of an issue. I think if they have symptoms, if they're symptomatic with severe stenosis and they're doing high-risk activity, yes. If they're asymptomatic, it gets very tricky. We don't know, it's very hard to counsel.
Yeah, no, I always look at that fluid column in the front of the spine as kind of the airbag of the nervous system. It sort of provides you that buffer when you have traumatic events. And so when I see a spinal cord that's severely compressed, the cushion around the spinal cord is lost. And so it always gives me a little bit of anxiety when I have a patient like that. But I think it comes back to anything. It's counseling, it's discussing with the patient the pros and the cons, and have them recognize that there may be consequences to their behavior based upon their imaging.
Yeah, and I always will it's very unlikely. So unfortunately, we do see it probably maybe 2 or 3 times a year. Somebody has a cervical myelopathy, has a bad fall, and does have a severe spinal cord injury. But it's still, the risk is very low. So it's unlikely you'll be paralyzed from it. So if anyone gets, I always warn them, it's okay, you're not going to get paralyzed from this. It's a very, very small chance. We do see it, but it's unlikely.
I know we always see a lot of patients in the office, and they say, I saw another spine surgeon or nurse surgeon say I'm going to be paralyzed. And I try not to scare people into surgery. You just sort of counsel them and explain to them, you know, what the potential consequences are, the pros and the cons of intervention versus observation. But it's oftentimes very frustrating to try and talk them down when they've been told, I'm going to be paralyzed if I don't do this surgery. And I'm sure you encounter that in the same way.
It's about 1 in 150,000 chance, so it's pretty unlikely. You know, there's far more risky things. One of the other big debates is, with movement, we know that compressive forces, so the big debate now is whether you should fuse a person or potentially do a disc replacement. Because while the disc replacement, you may maintain a movement, but some of the movement may be pathological or wrong movement and be compressing the cord. So the big debate, if you have myelopathy symptoms, should you have a fusion or a disc replacement? And I don't think we know the answers to that fully yet either. So those are things we're going to figure out gradually with time, as disc replacements are used as a good tool to help people. I always tell people a 2-level fusion or a 2-level disc replacement, they're both excellent procedures with their positives and negatives. And I think that's going to be a big thing. You know, for certain situations, can a disc replacement be used? No, but sometimes it probably can be. If it's a big, large disc herniation causing core compression in a younger person, yes. But if it's severe narrowing with congenitally narrow canal, probably not.
Agree. Anybody else? Questions for Dr. Murphy? No, thanks so much. Great presentation.